So, hello everyone. Welcome Post Eclipse to our fourth season, episode 8 of Gateway Center of Excellence in Rural Health virtual lecture series. The topic for today's lecture is Rural Hospitals to Home Transitional Care. My name is Gwen Devereaux, and I'm the president of the board of directors of Gateway. And Gateway is a rural health research organization with a mission to improve the health and the well-being of rural residents through research, education, and communication. We are located in Goderich, and to our knowledge, we're the only rural health research center in Canada affiliated with several academic centers. Before we begin, I would like to start by acknowledging the land that Gateway office resides on, the traditional territory of the Anishinaabe, Haudenosaunee, and neutral people under the dish of one spoon wampum agreed to care for the land and its resources by the Great Lakes in peace. This past Sunday, April 6th, was World Health Day. The theme for this year was My Health, My Right. Gateway continually works to promote health and access to healthcare resources for all those that live within rural communities across Canada. To spread education and understanding, Gateway is happy to have Dr. Mary Fox presenting today on transitional care interventions to support functioning in older people in rural communities. Mary Fox is an associate professor in the School of Nursing at York University. Her research responds to profound social and economic changes affecting healthcare today, such as patients being discharged quicker and sicker. Professor Fox is currently leading 2 studies on transitional care in rural communities. She has been credited with providing the evidence needed to make the case for ACE, a functional focused approach to older people's care and a fundamental pillar of Ontario's senior strategy. Dr. Mary Fox is joined for this lecture by 2 panelists. Anne MacLeod, practicing nursing in a variety of hospital and community-based settings in urban and rural areas in Canada, New Zealand, and the US. She has taught clinical and theoretical courses focused on care of the older adult, community health, and primary care in the Trent Fleming School of Nursing since its inception. Evelyne Durocher is an occupational therapist and assistant professor in the School of Rehabilitation Science at McMaster University. Her current research is focused on questions of autonomy, vulnerability, equity, and justice in healthcare, servicing for older adults. Her goal is to improve the health and social care experience of older adults, family members, and healthcare professionals. Throughout the lecture, we invite participants to ask questions of the panelists and lecturer. Please feel free to add your questions to the chat box on Zoom. A brief disclaimer: the views expressed in this lecture may not necessarily reflect Gateway's views or opinions, but we believe in providing a platform for a range of perspectives and thoughtful discussion. Looking forward to a wonderful lecture, and I'll hand this over to Dr. Fox.
Thank you very much for that very warm welcome. I'm going to start my slideshow here. Okay, well, I'm going to start off by giving you a background about why we're doing this work, and then I'm going to give you an overview of our approach we're using to designing interventions. And by interventions, I mean healthcare practice, a strategy, a treatment, and then I'll talk a little bit about how you might want to get involved. So for the background, what we've been focused on in this study is persons living with cognitive impairment. And by cognitive impairment, I mean it can range from trouble thinking, remembering, concentrating, and or making decisions, all the way to having an actual diagnosis of Alzheimer's disease. And people with these conditions are at high risk for hospital admission and readmission compared to those without cognitive impairment. And there's a big risk of functional decline that they can experience while they're in the hospital, and also 1 month after discharge. And by functional decline, I mean physical and cognitive functioning, things like doing everyday activities like getting dressed, getting around independently, going to the toilet on your own, things that we take for granted every day. And there's a lot of research now that shows that if people don't regain what they might have lost in hospital over that 1 month post-discharge period, they're unlikely to ever regain those functioning abilities. So we use the term cumulative functional declines, which refer to the physical and the mental ability to do their usual activities. And so we have a service called Transitional Care, and this is a health service that supports self-care and recovery after a person goes home from the hospital. And it starts in the hospital. And by self-care, I mean being able to take care of yourself, knowing the things that you need to do on your own to get better, to return to your usual activities and your functioning. And transitional care starts in the hospital. And so before people leave the hospital, they need to receive the information on how to get back to their usual level of functioning. And we do have transitional care research, but most of what we know from transitional care research has not focused on functioning or how older people with cognitive impairment can get back to how they were functioning before they went into the hospital. Much of what we know about transitional care is from research done in urban areas with people who do not have cognitive impairment. And so this really limits the applicability of transitional care to people with cognitive impairment who live in rural communities. So we know from that we need to develop interventions or strategies as part of transitional care that support a person's functioning after hospital discharge for a medical condition, and supports families and other care partners' ability to promote patient functioning, and will work in rural communities. Now I'm going to talk about how we are developing these interventions for transitional care. And so we're using a participatory approach, and the approach has 3 features. The first one I'm going to talk about now is on developing the team. And so we've developed a team of community representatives who bring their knowledge of the lived experience. So people living with dementia and their family members. The team also consists of clinical leaders who bring their expertise of rural healthcare. And this includes administrators, various clinicians who are part of our team, hospital administrators, community care workers. And we also, in our team, have researchers, and these researchers have complementary areas of expertise, such as rural health, expertise in aging, expertise in intervention design, and transitional care. And in this community participatory approach to intervention design, we involve all members at the different phases of intervention design. And so now I'm going to talk about the second feature, which involves developing the interventions. And so the first part of developing an intervention is having a really good understanding, a clear understanding of the problem. And our understanding of the problem came through our prior research, our review of the literature, and discussions with healthcare professionals across Canada, and our team of clinical leaders and patient and family representatives. And we learned that older people living with cognitive impairment are often admitted through the emergency department. And I probably don't need to tell you what a stressful environment that is, both mentally and physically. I know when myself or family members have been in the emergency department or emergency room, when they come home, they're really exhausted, you don't sleep well, there's a lot of noise. So you can just imagine what it must be like for somebody living with a cognitive impairment. And then once they get into hospital, they don't sleep well. Their participation in their activities of daily living, particularly getting dressed, patients are usually in gowns, is restricted. And they're very sedentary in hospital and after discharge, and they're tired when they get home. So we can see that this population will experience problems in their physical and cognitive functioning. And also when they get home, sometimes they're so tired that they're just even more sedentary when they get home. This phase also involves us asking, okay, so what's modifiable? What can we change about this problem? And so we know that we can change, we can give people education on what to do after discharge. And knowing the problem is very important because it helps us to design the interventions. So if somebody has poor sleep, we know we're going to need an intervention that addresses sleep, because many people who've been in the hospital, even for a few days, they go home and they no longer are on their regular sleep schedule. And so they might have a sleep problem. So we need interventions that address sleep. If they've been on bed rest or had very limited physical activity, what happens in our body, we have detectors that know when we're lying down and getting up. When we get up, these detectors make sure that our body pumps blood to our heads. Sometimes these detectors don't work so well when we spent a lot of time lying down. So when we get up, we don't get enough blood going to our heads, and we experience what we call in research orthostatic intolerance. And so what that really means is the inability to handle or tolerate being in an upright position. And so what people tend to do when they experience this is they lie back down, which kind of just makes the problem worse, because our detectors stay very sluggish. And so because of that, we know we need interventions to address orthostatic intolerance. We need interventions to address walking, to help people get back to walking and be safe while they're walking. And because of the restrictions in performing activities of daily living, we need interventions to address self-care, like how to get back to doing your usual activities. People also, when they come home from the hospital, they're very, very tired, many of them, and they might have trouble thinking clearly, which might even be worse after a hospital stay. So they might have trouble communicating. And so we need interventions to address communication, particularly for family members who may not fully understand why there's such a big change in their relative. And we know because of the sensory disorientation with being in the hospital, you may not have a clock, you're not going outside, getting that natural sunlight. So we need interventions that promote orientation. So what we did is we reviewed the literature and we pulled out information on evidence and on the evidence for these interventions. And we also pulled out information on what is the content of these interventions, what did they involve. And so now I'm going to give you a little bit of a picture of what we did and how we mapped everything out onto an Excel file actually. And so we looked at what is part of the problem here in the left-hand column. And so we saw through we know through the literature that bed rest leads to changes in the cardiovascular system, those detectors that I told you about earlier, and changes in our muscles. And so we then designed an intervention component. So the first one is being upright. We know that the best way to help get back to our usual activities and be able to tolerate being up is to actually be up. And so our recommendations for this part of the intervention is to get up slowly, because people aren't used to, after they come home from the hospital, they're sometimes not used to getting up. And so we want them to get up slowly so that they don't feel too dizzy. The second recommendation is to sit on the edge of the bed for up to 3 minutes so that their body gets used to being up. And then our last recommendation for that one is to gradually start to increase being up to at least 3.5 hours a day as the person can tolerate it. The second one of the component of the intervention is trying to stimulate blood flow by activating the muscles in our legs. So we found through the literature that we actually found a study that had tested in the laboratory rocking in a rocking chair, and that was found to improve blood flow. So that's kind of what we did by reviewing the literature. And this is what we used for the researchers. And this is what we took that same information and we put it in a table for healthcare providers so that they could understand what the intervention is about. And we developed a written description for each intervention. And here's the example of the orthostatic tolerance intervention that I went through with you in the last slide. And for healthcare providers, of course, this is very, very detailed. So I've provided here the structure of the kind of information that we're providing for healthcare providers. We also package this information into pictures with written descriptions for patients and families to help them understand and remember the recommendations, which I'm going to show you now. And I'm going to use the same intervention, the one for orthostatic tolerance, and give you an example of what it looks like for patients, families, and their other care partners to understand. So you'll see here the first picture that patients and families look at is that too much rest can make you feel dizzy and weak. And then the next one is before standing, get up slowly and sit on the edge of the bed or the couch for up to 3 minutes. The next one is do 3-foot exercises 2 times a day. And so you'll see there it has circle feet, lift your knees, and lift your heels. And these are designed so that people at home can look at the pictures, and it serves as a reminder of what they need to do, and they can review it on their own, and they could ask their healthcare provider questions based on it. And here's another one: be up for at least 3.5 hours throughout the day. And it doesn't mean they have to be up for 3.5 hours all at one time, but 3.5 hours all together throughout the day. And here's the last one that I told you about earlier: rock in a rocking chair, if you have one, if available. And we brought all these pictograms and intervention materials to people whose lives have been affected by cognitive impairment to get their perspectives. And you're going to learn about that in the next presentation by Professor McLean. The next part, the last part of our approach to developing interventions to promote older people's functioning is evaluating the acceptability of each intervention to people who are going to use them. And the reason why we do this is, if an intervention is not acceptable to us, are we going to do it? It's highly unlikely, right? If it's too difficult to do, if it's too burdensome, it takes too much, it's unlikely that that will do it. So it's very important for us before we go full-fledged with this this intervention program, is that we gather the perspectives of patients, families, and healthcare providers who are going to ultimately use the intervention. And we also did a mock interview of this evaluation process with our community representatives so that we know how to engage members of the community. And we incorporated their feedback as well. And so this slide here, it speaks to how we're engaging patients and their care partners and healthcare professionals as research participants to gain their perspectives on whether or not each intervention is acceptable to them. So in terms of acceptability, we're looking at gathering, tell us about, do you think the intervention will be helpful to you? How easy do you think it will be to use? How relevant is it to your situation? And we're also looking at what do you think are some barriers to using it, or some facilitators? Do you have any suggestions for improving and adapting the intervention so that you can use it at home, or you can use it with the people you're working with? And so that's where we're at right now. Actually, we're still recruiting for the study. We're still working on it, and as you can imagine, recruiting people who are in the hospital and just about to go home, or just got home from the hospital, can be very, very difficult. And so if you're interested in getting involved, we'd love to hear from you. We really believe it's so important to hear the voices of people who will be using the interventions to help us make them as good as we can and as usable as they can. And I put the flyer up here to let you know about our recruitment flyer to indicate that we're looking for patients and their family members or care partners. And we're also looking for healthcare professionals to participate in our study. And on that note, I'm going to end my presentation, and I believe Gwen is going to be introducing our next speaker.
I actually introduced everyone, Mary, at the beginning. Okay. So we'll just go forward then. Our next speaker is Anne. Is that correct, the order?
That's correct.
Okay, so I won't redo it, Anne. You can maybe speak to, yeah.
Sure, I will just. Can everybody see my screen now? Great, great. So I got involved with the project through the Trent Center for Aging and Society. And what was interesting was that my dad was also experiencing cognitive impairment, and my parents were transitioning from a rural town called Perth, Ontario to Peterborough, partly because of their hospital experience and availability of home care were not so available in that little town, and they were needing a lot of support. So after my mom died, my dad was looking for a way to engage in meaningful activities. So thinking back to Mary Fox's discussion of our approach to developing the interventions, even developing the team, Mary and her team were very inclusive of not only myself, but my dad as well, being a retired scientist, was very curious about how does one do research with older adults. And so he previewed materials and the grant application that included things like, what does this all mean? And provided feedback on letters of information and recruitment, making a little bit more clear language. So that was in the developing the team phase. And in the intervention mapping, I was involved in the review of the literature through looking at the communication interventions, and particularly those interventions that were around people with cognitive impairments, and as well transitioning from the hospital to the home. In my role with the School of Nursing, we have community placements where we have students placed with the Alzheimer's Society. And being new to Peterborough initially, and having a lot of contacts in Peterborough, I signed my dad up for various community supports. And one of the supports that we signed him up with was that of the Alzheimer's Society, their First Link program, as well as a support group. So that group of people with cognitive decline, as well as the staff, were approached to look at offering us feedback on the interventions, particularly the pictograms. And we had the entire slide deck, and participating in their support group were 8 people with cognitive impairments and 6 of their care partners. The staff helped me out in a role of recruiting their participants, as well as recording and wrapping up, as well as providing feedback themselves separately, just online. So this is literally kind of what it looked like on our flip chart. We asked the members to do a thumbs up or a thumbs down on whether it was acceptable or not, describing a little bit about each of the interventions. And there was a lot of dialogue, I can tell you that. Again, just to go through the example that Mary had given from the beginning, this literally is what the first slide used to say in the I'm going to call it our pilot pictograms. And particularly the older adults looked at this, and they thought, well, there's too many words on this, for one. And am I really going to do the math, subtracting 24 hours or subtracting 20.5 hours from 24? And so they decided their recommendation was to break it into actually 2 slides, and to do the actual positive statements, as opposed to them asking them to do the math. So this was the result, that too much rest can make you feel dizzy and weak. So to them, the fewer words and just a clearer message on that was what they were looking for. And then it was broken into, the other part, we did the math for them, and they showed somebody beside them to help them get up, but be up for at least 3.5 hours a day. And the talk around the room was that can be a little bit in the morning, and it can be a little bit in the afternoon, or for at least an hour around each meal. So that was kind of how they discussed it. So we took notes during the group, and this is what the notes looked like. And this was the piece that was critiquing, again, a few too many words, and that notion of a clock they wanted made a little bit simpler and reduce the words in general were their comments. So this is what we ended up with just a simple directions with the 3 minutes and quite large writing, because some of the talk around the table was maybe I don't have my glasses on, or my wife's in the other room, and she doesn't know. So that kind of information was discussed and provided back to the team as well. And this literally is my dad's bedside table. And so I can attest that it works. And he does use the timer. If I'm, for example, paying bills or making some food in the other room, I will hear the timer go off. And then he will find his rubber-soled slippers and I'll go in and help him up. So that kind of gives you a picture of what it looks like in real life. Any other questions? I guess we'll pass it off to Evelyne, who's our next presenter.
Hello, thank you very much, Dr. Fox and Dr. MacLeod. So I'm going to take us in a slightly different direction right now. So I'm just adjusting. And to talk about when we think about these approaches and when we think about these interventions, about what are some theoretical approaches that can help guide the way that we're thinking. And so I'm going to talk a little tiny bit about relational autonomy and how this can help us to understand persons in their contexts and some of these changes that they may be experiencing both in themselves and in the context. And so some of you may have heard of relational autonomy theory in the past, but just a quick recap. In relational conceptualizations of autonomy, these arose as a critique to more traditional views where individuals were viewed as independent, rational beings who were able to make decisions separate from their contexts, about their contexts. And in feminist perspectives, this was seen as perhaps being unrealistic. And so in such perspectives, individuals are considered to be multidimensional in their contexts, and their contexts are layered. And so there would be the political context. What are the social structures? What does the health system look like? What are the services available? What is the social context, which again is multi-layered and would include the people in the immediate sphere, so care partners, people with whom one lives, people in your neighborhood. Then if we move a little bit bigger, people in your town, people in the country, and finally as a citizen of the world. But then there's also the physical context, which is the physical environment, usually most closely where one lives. And so it might be their home. Do they live in an apartment? Is it all on one level? Are there stairs that an individual may need to go up or down several times? Is there an elevator? What amenities are there? And then within those contexts as well, what are some of the things that are required of the individual that they may need to do? And so in order to eat, are they required to make their meals? Are they required to, is there an opportunity to garden? Or what are some of the opportunities that are there? And what are the things that need to be done? And so from a relational perspective, people are perceived to have been both shaped by these contexts, and so they've learned from the opportunities that they've had, but they also have not learned from the opportunities that they've not had. And then they're always acting in their context in relation to the opportunities that are there or the requirements that are there. And so why are we talking about that specifically today? Because in these transitions, it might be helpful to consider how a person is in the context now, but also how they were in their context previously. And so previously, they may have had all of the abilities required to navigate that environment at home. They might have had the strength to climb the stairs when they needed to prepare their meals. They might have had the just right amount of help at the end of a phone call or from a spouse or someone who lived in their context. But in having been admitted to inpatient care, first of all, the reason for admission might have also included changes in their abilities. And subsequently, having been in the inpatient care for a while, again, their abilities may have changed. And so they may have changed, but also so has the context. The setting in acute care is quite different frequently than the setting of a home. And so in the acute care, you might have a room with a bed. There's a lot of equipment. There's likely a very large bathroom that's right there. To walk down, you might have to walk down the hall a little bit. You might have to get out of bed. There would be elevators, large flat hallways. In terms of the social context, there would be many individuals to help and to pay attention to any small or large need, medical or otherwise. And there may be family members, but perhaps not at all times, but there always are healthcare experts around. In terms of tasks and occupations that a person might be doing in the hospital or in inpatient care, there are not demands like preparing meals or cleaning up or doing laundry. And so the context, the demands, and the opportunities are quite different. There are also different social roles when a person is in inpatient care. And so people may perceive themselves as patients and in the role of a patient. And the fact that they might be in bed most of the day and would be doing what is expected of a patient. And so this, compounded with the fact that their needs are being monitored and met by trays appearing with meals on them, trays disappearing, bedding being changed, will all change the expectations this individual has of themselves in that setting. And so when they do return home, a lot of the context is again going to change. It's going to go back to that home setting. And so there may no longer be a fit between what they're able to do and what they're required to do. Having said that, they can step back into previous roles upon their return, but with a lack of support that they had in the hospital, it might be difficult. And so in such transitions, it's really a matter of finding that fit. And in finding that fit, this is what we're trying to do in this project, between the demands of the environment and what the person is able to do. And so it's important to remember that it can be difficult for individuals to envision how they might look upon discharge when they're back in their home environment. They might imagine themselves back home with the capabilities that they used to have. And maybe that will be so in the future again, but likely not right away. And so it might be difficult for patients to imagine this throughout the transition. Similarly, it can be difficult for healthcare providers to envision how the person might be in their home environment. And in these care transitions, it's important to have everyone communicating and bringing what they see and know to try to maximize this person's experience. And so taking a relational approach really helps us to consider the person in relation to their context and how both of those might be changing, the context as well as the individual. So that was a little bit of a theoretical consideration to some of these projects, but we would invite discussion and conversation about all aspects of what's been discussed today. Thank you very much.
So I'm back to you, Mary, for the question and answer period. And I think Jay is going to take some of the questions that we have. Plus, I think you have a number of questions as well. So I'll put that back to you, Mary.
Sorry, I'm just going to have a look. You want me to respond to the questions?
Sure. I could pose the questions to the group, Mary.
Okay, great. Thank you.
We do have a few here. I'll point out just some of the top ones. I think this is directed more towards Mary, but I think we'll hear from all the panelists. Brian Smith is saying, would this research suggest that personal trainers should be added to the kinds of home care? And I know this is another hornet's nest that we could kick down the road, but provided personal trainers after release from the hospital. What do you think about that?
Well, I mean, that is an idea, but much of what we're suggesting here is that, slowly getting back to your usual activities should help you to get back to what you're usually doing. Of course, personal trainers would be wonderful. I don't know if you know, when we talked about our approach, we looked at what is modifiable. And so the flip side of that is what is feasible as well. So I don't know that we could make that recommendation in terms of personal trainers, but if anybody does have access to a personal trainer, I think that could be wonderful after a hospital discharge.
Thank you for that, Mary. And Anne or Evelyne, anything to add to that, or there
Well,
are other questions?
I can speak of personal experience as well as in the role as a past home care nurse, in that often there is outpatient physio clinics as well as physios who will visit in the home, as well as occupational therapists. So I found it very helpful to have an occupational therapist come and do a home assessment and figure out where bars should be, moving different appliances from the basement to up, to the main floor, and things like that. Now, it was a physiotherapist before they resumed activities at the YMCA, for example, where they did access personal trainers. But they can also make use of some of the community resources through community support services. I know that Alzheimer's Society has a Minds in Motion for people with cognitive impairment that is a social and physical activity virtually, but also in person, as well as community care. Peterborough, they offer daily Zoom exercises. They're not necessarily, well, they are trainers, but it's not necessarily personalized. So I like your idea of a personalized trainer, but I also think we need to consider the social determinants of health and incomes of an accessibility to the services, particularly in rural communities, when we'd be making recommendations that they be affordable.
And the only thing that I would add from an occupational therapy perspective is that, yes, personal training and explicit exercise is quite good, but at the same time, as we know, the World Health Organization and occupational therapists propose that health is both a resource for everyday life, but everyday life also contributes to health. And so doing exercises is not necessarily always the most meaningful thing, but perhaps going for a walk with somebody or just all the things that you do inside your home are much more meaningful, perhaps. And so just ensuring to engage in those activities as much as possible, and as from a care partner perspective, to engaging the person so that they are engaged in doing it and not doing everything for them, because the more that is done for them, the more that they'll also lose. So ensuring to just maintain regular activities of daily living, and that's also going to maintain your health.
Great, thank you all for those answers. I figure I'll turn my video on if I'm going to be speaking here. So I see another question from Brian Smith about the hospital environment. And he's thinking specifically about the dry air, the room temperature, disinfectant, other odors. Do you think that the quality of stay, or perhaps how well the rural hospital room is appointed, because there's quite a range in our rural hospitals, do you think that could have an impact on the hospital to home transitional care?
That's a good one. I don't know much about that area, so I'm reluctant to make a suggestion or a comment. I don't know if any of the other panelists have anything to say.
I can speak a little bit about delirium and the kinds of triggers for delirium, which is a type of, it's a transient cognitive change that results when people, especially older adults, may experience an infection or a change in medication, but there's a number of causes for that delirium. And there's a number of triggers that can accentuate the responses during that in-hospital stay. So I think a really good, making sure it's transitional delirium and that's resolved, and the triggering effects of the delirium are addressed, no matter whether it's rural or urban. And knowing that returning to home, those kinds of triggers to, cognitive impairment should be removed if possible from the environment, whether it's too much stimulation or too little stimulation. And that kind of discussion, is part of our interventions with the communication, like turning down the radio, turning down the TV so that it's the right volume, so that you can interact, having lighting. So a lot of those kinds of things. Evelyne, do you have anything to add as well?
I get the only other bit that I would add, and this also kind of relates to one of the questions lower down, but that in terms of what's exhausting about spending time in hospital, I mean, it's such a busy environment. It's not one that is familiar to the patients most of the time. And so there's always something happening. It's always a novel noise, a novel activity, a novel, routine, and so on, which is definitely exhausting. And so the other comment later on is about advantages of being in the home environment and knowing and being familiar with that environment. Definitely, I think it's much more restful because cognitively, because one knows everything that they're going to be expecting. And there definitely are advantages to being in familiar environments, but that's the only piece that I would perhaps add.
Great, thank you, Evelyne. Okay, I see a question here from Jody Houston. Transitioning folks home often relies the aid of family, friends, and neighbors for things they may not be able to do, like lawn work and house cleaning. So what supports do you suggest to folks who live in rural communities who are isolated, realizing that the MOW is not always available in every rural community? It's kind of a big question.
Yeah, that is a big question. I suppose using technology like a telephone or what we're doing here to walk you through the interventions and to help people after discharge. We have had in our prior work, we had people who were quite far from healthcare. They could only access healthcare by a helicopter, for example. And most of those were really reliant on community members within their community, and haven't had anybody, like, they seem to have good support from family and friends and neighbors. So I haven't had anybody in our research say that they didn't have anybody at all. But I suppose if they have relatives who live quite far from them, using technology, that, and technology seems to be changing every day, it seems. Mm-hmm.
Right. Evelyne or Anne, anything to add to how isolated rural seniors may access better care at home?
We, in another study that I led during COVID, they did actually find that they felt quite isolated, and it was very disruptive for families, especially during COVID in terms of relocating to rural areas and not having access to their usual, visits or things like that. So particularly during the transition from a hospital, which might be in kind of an urban area, to their home, which could be very rural, and depending on the season, neighbors were either able or less able to help out checking in on them. So communication technology was one of them that our participants mentioned in that study, but also really finding out and having open communication about resources that are available to travel to the home for those types of supports. So again, the community support services organizations often act as brokers for people to help out with things like yard work, stacking wood, shoveling, home maintenance, grocery delivery. So it's really important for our care managers who are helping with that transition from hospital to home, to identify all the local resources, both formally available, like through community support services, but also informally, which might be the faith community guilds that often look after like food access. Evelyne, do you have anything to add there?
I don't really have anything to add to what both you and Mary have said. The only thing I would say, I'm reading the chat as well, and I just wanted to say about Tressa's comment about that sometimes there are occupational therapy assistants who can help with these, and similarly, but there's not enough, and there's not enough home care or home assistance. I mean, we're all aware. So I just wanted to acknowledge that definitely we would love it if there were more, but sadly there isn't enough.
Great, thank you everybody for your input on that one. I have a question from an anonymous attendee about the interventions at home, asking why is it not possible to commence these interventions while in hospital?
Well, that's a good question. It is possible to start many of them in the hospital, and particularly, the one we went over, getting up out of bed. There's in the last, I guess, 10 years, so much movement to try to get people up out of bed. Like when I watch shows from the 60s, the nurses are like, get back to bed. I didn't tell you, I told you weren't allowed up out of bed. We don't do that anymore, right? We really try to get people up out of bed and get them walking, but sometimes there are limits to what the staff can do, and also what people can do. But we can start many of them in hospital, and actually that is the ideal. And then teaching patients and families how to continue them once they get home is also ideal.
And so I think that is where some the occupational therapists and members of the interprofessional care team do work with people in the hospital. And as an occupational therapist, one of my jobs was to help individuals to practice these things, but also to teach family members or individuals who would be helping them upon their return home. So I would argue that they do, but there can sometimes be, again, a lack of time, and with high caseloads, there's not enough time to spend with each individual, but we definitely spend as much time as we can and ensure that we get everything done that needs to be done before they can go home.
And the other thing is, I've had some relatives frequent the emergency department in the last couple of months. And you could have your whole treatment in an emergency department over 3 months. So you could be admitted to emergency department. There are no beds on a regular unit, and you're there for 3 days. One relative said to me, like, I was so busy, thank God I had my daughter there. So I don't know. I mean, I've never personally worked in an emergency department. I'm just saying from what I've heard from people who've told me personally and in my research, is that it's very difficult to do some of these things while you're in an emergency department on a stretcher or in a chair, having your treatment over a few days.
For some of the patients who are in units for a little longer, the McGill Needs-Driven Model has created an All About Me program. And it, particularly for patients with cognitive changes, it does a really nice profile of suggestions and also visual cues for different staff who are coming and going, interacting with particular residents around person-centered care and approaches that might be helpful and those that might be less helpful. So a lot of seniors friendly hospital initiatives are adopting that All About Me signage and use, and assisting with that hospital to home transition as well.
Okay, Gwen.
Okay, I'm back, and thank you so much. I think that there were little clues there all along, and I know we're all facing such a shortage of healthcare professionals, and in an ideal world, we'd have home care come in and go through all these things, and you would have someone in the house as a partner, but it's not always that way. So Mary, doing the exercises, I've been sitting here doing the little exercises you showed on the screen, and I think that we just need to be reminded, and particularly the one about the 3 minutes before standing and getting up. You know, we forget that one, and we know that one's so important and can stop many falls from occurring. And Anne, thank you for your father's example. I think particularly the photo with the timer and the sign. You know, you need those cues. We all do, even if we're not, well, some of us maybe not as cognitively impaired, but you know, those remind us. And I thought that was really good. And Evelyne, I agree with the care transition and expectations. You know, the inability when you're post-hospitalization, you know, you want to go back and you then can't maybe do the things that you did before. And that's an area that I appreciate you covering. It was, it's so true. So in closing, I hope everyone has found this educational in that rural transitional care intervention. And I hope many people will sign up for the research. It's so important. So a huge thank you to our panelists and to our lecturer, Mary. And we would like to thank our sponsors for their continued support. Without them, the lecture series would not be possible. And this includes MicroAge Basics in Goderich, McGee Motors in Goderich, Libro Credit Union, Lighthouse Money Management in Goderich, McEwen and Fagan Insurance Brokers, and Huron Telecommunications, Zayers in Goderich, and CIBC Wealth Management, and the Goderich Royal Canadian Legion, Branch 109. Gateway Center of Excellence in Rural Health is a not-for-profit organization with charitable status, and we greatly appreciate and welcome any support we receive. If you would like to donate to Gateway to support this lecture series and our other health projects, I encourage you to visit the Gateway Center of Excellence in Rural Health website. Gateway is excited to announce that the Discovery Healthcare Camp 2024 registration has opened. This is a week-long summer camp from July 8th to the 12th for high school students. So please let people know, and we want to get a full group of students this year. So you can sign up now through the link at Schulich School of Medicine and Dentistry page found on Gateway's website. Our next lecture is a bonus lecture on Tuesday, April the 23rd from 12 to 1 with Erin Donald, and who is the Director of Clinical Services at the Huron Hospice, and Dr. Megan Nolan, who is the Medical Director. She will be speaking about the role of the hospice, or they will be speaking about the role of the hospice in our community, and we hope to see you there. And thank you, Jay, for all your support.
Great. Well, thank you to the whole team, and everyone have a lovely day.
Thank you.
Thank you.